Hi guys, this is David Villar and welcome to this video that will discuss the different syndromes that can be produced by copper intoxications. As you all know, copper is an essential metal that plays key roles in numerous biological processes, so we can see problems in both extremes with deficiencies that we'll see in a separate video and with an excess that we'll address on this video. On this image, we see these being represented by the concentrations of copper in the liver, which is a better indicator than serum to know the mineral status in which the animal is. Liver is the main storage organ and the best tissue to know if the animal is either deficient or has an excess of copper. Acute copper toxicosis is not common in animals but has been reported, as we will see next. What is more common is chronic exposures in which copper accumulates in the liver to toxic levels. And this graph looks kind of difficult to comprehend, but I'm going to try to explain it slowly to show what happens in ruminants. As we can see on this slide, there is a very complex interaction between different elements. We can see that molybdenum and sulfur are antagonists of copper. The two of them bind in the rumen to form thiomolybdates, which in turn bind copper and prevents its absorption in the intestines. Now, if the thiomolybdates without the copper are absorbed in the intestines, when they reach the bloodstream, they will bind copper containing enzymes and will inhibit them. Now, another interaction is with iron. The copper, the iron, and the sulfur all bind together in a complex and prevent the absorption of all of them, and they get excreted with the feces. And it has been shown that both iron and sulfur supplementation reduces both copper in plasma and liver. So the take-home message is that clinical copper deficiency can be either a primary deficiency due to lack of copper in the diet, or it could be a secondary deficiency due to the inhibition of normal copper homeostasis by the antagonistic minerals that, as I just said, are molybdenum, sulfur, and iron. As we can see on this image, the molybdenum with the sulfide will form a complex that binds copper, and so does sulfur and iron. If there is too much molybdenum in the diet, it will be absorbed and become toxic to copper-containing enzymes. So the way to prevent this will be giving more copper to prevent the absorption of molybdenum. On this image, we see that tetrathiomolybdate will bind to ceruloplasmin through the sulfide groups, and by reducing the divalent copper to monovalent copper. If we measure the activity of ceruloplasmin and it's low, but the copper is normal in serum, we can diagnose a molybdenum toxicosis, which would be clinically very similar to a copper deficiency. Now, there are other enzymes that are also affected by molybdenum toxicity, which are listed here. For example, I'm just going to mention one. Impaired tyrosinase activity is responsible for the depigmentation of the hair coat because the melanin cannot be produced. So the treatment is going to be giving copper sulfate in the feed to prevent the absorption of those thiomolybdates in the intestines. On this slide, we see that toxicity by either copper or molybdenum results when there is an imbalance between the two elements in the feed. The ideal ratio of copper to molybdenum is 6:1. If that ratio is less than 2:1, you get molybdenum toxicity, and if that ratio is more than 15:1, you get copper toxicity. In general, ruminants, unlike other animals, species, do not have an efficient regulatory mechanism to eliminate copper. This is actually an adaptation to graze in copper-deficient pastures, and they have developed mechanisms for storing copper in the liver by decreasing its excretion in bile. So when they're exposed to concentrations above physiological requirements, the excessive copper accumulates in the liver, and when it reaches a critical point in which the reserves are overwhelmed by prolonged or chronic exposures, they will release all that copper at once, producing hemolysis that will result in hemoglobin casts in the kidney and hemoglobinuria, and this is called a hemolytic crisis and happens particularly in sheep. So what are the typical sources of copper? Well, number one is an excess in the diet. In sheep, the most common is misuse of bovine feeds. A lot of people will think that sheep are small cows and will feed them with bovine diets, and in several weeks they will build up toxic levels of copper in the liver. If the requirements for sheep are about 10 parts per million, a diet for bovines will typically have between 30 and 40 parts per million. And the same can be said for bovines. If they're fed chicken or swine diets that contain levels of up to 200 to 250 parts per million, they will get also chronic copper toxicity. Now, other sources that we will discuss is the injection with copper salts, or for example, the exposure in pastures that are fertilized with chicken litter or swine manure. And there are reports in the literature of bovines intoxicated when they were given chicken litter. So what are the clinical signs by either deficiency or excess of copper? We will discuss in another video the deficiency of copper, so I'm not going to say anything here, but if you like, you can pause the video to read them. In sheep and to a lesser extent cattle, when copper builds up to 150 parts per million or more in the liver, an acute clinical syndrome of chronic copper toxicosis is initiated by the sudden release of copper from the liver into the blood. This may happen spontaneously, but most commonly happens after some stress like handling or moving those sheep around. And the hemolytic crisis affects only a few animals, maybe just 5% of the flock. But they all are prone to develop that crisis, and that's the reason why we should treat all the animals in the flock. Copper will cause hemolysis or red cell destruction by oxidative reactions like lipid peroxidation, and the urine will have a red or coffee color, and the mucous membranes will be icteric, but sometimes you may just see pale mucous membranes. So because the morbidity is low but the mortality is almost 100% in affected animals, we have to protect the rest of the animals in the flock, as we will see next. This is a paper that we published from more than 100 cases submitted to the Iowa State University of sheep diagnosed with chronic copper poisoning. Ideally, you want to submit both liver and kidney and the diet fed to the animals. And the laboratory interprets copper concentrations in liver as toxic when the levels are more than 150 parts per million, and for the kidney more than 10 parts per million, and the diet with more than 15 parts per million. This graph shows the number of cases at the different ranges of copper concentrations in the liver. As you can see, at more than 150 parts per million, the concentrations are already considered toxic in sheep. These levels are about 1.5 to 2 times above the normal levels, and obviously you need to put those values together with a hemolytic crisis, because most of the animals in the flock will have those high values in spite of being apparently healthy. For the kidney, it was typical to have concentrations of 4 to 10 times above the normal range for kidneys. So the value of the kidney as the organ of choice to diagnose copper poisoning is better than the liver. If you had to choose one or the other organ to submit for analysis, we see that the number of cases at the different ranges of copper start at 11 parts per million, and the normal values in sheep are 4 to 5 parts per million. So the take-home message is that the kidney provide more diagnostic value than the liver in cases of a hemolytic crisis. Now, if we look at the diets, usually they had more than 15 parts per million with low molybdenum below 1 part per million. Here we see the number of cases at each of the different copper to molybdenum ratios. And as we said before, diets in sheep with a ratio higher than 10 to 1 will cause copper to build up in the liver. Now, when you do a necropsy in sheep, the gross lesions will typically be a yellowish mucous membranes or jaundice, and very, very dark or gunmetal colored kidneys. Obviously, there are other diseases that can cause similar lesions, so I'm not gonna. You cannot put too much emphasis on these lesions unless you do the measure for the copper in the kidney. But you can have similar lesions with leptospirosis, some clostridial bacteria like Clostridium hemolyticum that causes bacillary hemoglobinuria, babesia, anaplasma, and probably some other ones. Now, the microscopic lesions will show individual necrotic hepatocytes and bioaccumulation both intracellularly and in canaliculi between the hepatic cords. Here is an example of a 4-year-old Suffolk ewe in which the liver had 260 parts per million. And here we see the same animal, but the image is of the kidneys. You can tell the tubular lumens in the kidneys contain granular and eosinophilic material, which is actually hemoglobin casts. And this kidney had 19 parts per million of copper. Now, moving on to treatment, we need to treat the entire flock if we diagnose any cases of copper poisoning, because all the animals are likely to have an excess copper in that liver. We could use chelators like penicillamine to increase the excretion through the urine, but this would be cost prohibitive for treating on a flock basis. So if we want to reduce or prevent further hemolytic crisis, we have to supplement those diets with molybdenum and sulfur, which, as we mentioned earlier, are the antagonists of copper. We can give ammonium tetrathiomolybdate to remove copper from the liver by forming a complex that is excreted in the bile, but the most feasible option to the farmer is adding sodium molybdate together with calcium sulfate in the feed for 3 weeks. An easy calculation is adding 4 kilograms of sodium molybdate and 2 kilograms of gypsum per ton of feed. Experimental evidence has shown that this promotes the copper excretion through the bile. Now let's see an unusual presentation of copper toxicosis. This time by injecting copper disodium EDTA in calves to prevent copper deficiency. Now, in the paper, they describe 2 incidents with very similar presentation. In one of them, they had 200 weaneling calves weighing more than 150 kilograms, and they were given an injection of copper EDTA, vaccines, tetracycline, ivermectin. The dose of copper was about 2 times what is recommended for each calf, which is about 60 milligrams per calf. And after 12 to 36 hours, 20 of the animals developed dyspnea, head pressing, ataxia, circling behavior, and 16 of them died within 72 to 96 hours. The necropsy in 3 animals showed very congested, heavy lungs, and the main lesions were of severe, extensive necrosis of the liver lobules. All the hepatocytes had mostly disappeared, and they were replaced by blood, just like when we talk about microcystin. There was a mild kidney degeneration, and there was no evidence of a hemolytic crisis like we see with chronic copper poisoning. The concentrations of copper in the livers were normal, and those in the kidney were very slightly elevated, but nothing compared with the expectations if this was a chronic copper poisoning. So the conclusion of the case is that acute copper toxicosis produces massive hepatic necrosis in the absence of hemolysis. And they also show that neither liver or kidney are good tissues to diagnose copper toxicosis based on their concentrations of copper. Now, to end these presentations, let's look at what happens in certain dog breeds, particularly West Highland White Terriers, Doberman Pinschers, and particularly Bedlington Terriers. These breeds have an autosomal recessive trait that causes increased copper retention, and when the lysosomal capacity is overwhelmed, then liver injury starts to happen. There are three syndromes that are described in young dogs. They tend to exhibit anorexia, lethargy, vomiting, weakness, and in older dogs they show the same thing, but they also manifest ascites, jaundice, and hepatic encephalopathy. Now, one of the microscopic lesions is a chronic active hepatitis, and the concentrations of copper in the liver are usually greater than 1,000 parts per million on a dry weight basis, when the normal values are between 100 and 50 parts per million. I thought to bring up a study in Doberman pinschers that were followed in time to assess the progression of the disease. The first objective was to see how many animals that were apparently healthy had subclinical hepatitis determined by liver biopsies. There were 22 out of the 106 animals that had liver lesions, and the copper concentrations in the liver were already elevated at 419 parts per million. After 2 years, there were 16 of those 22 dogs that were available for follow-up and could be reassessed, and only 5 of the 16 had similar lesions, but the concentrations of copper in the liver had increased from 419 to 939 parts per million. They then injected radio-labeled copper and found that the animals could not excrete that radioactive copper. And the conclusion was that the animals had a defect of the enzymes involved in the excretion of copper. So when should animals be treated? Well, basically, when the copper concentrations are greater than 350 parts per million, and they are associated with clinical signs of disease and elevation of liver enzymes. So this study was follow-up in those 5 dogs that had liver lesions and elevations of copper in the liver. The black bars are the concentrations of copper before the treatment with penicillamine, which is the chelator for heavy metals. And the columns with the diagonal bars are the concentrations of copper in liver 4 months after the treatment with penicillamine. So we can see the difference between before and after the treatment in the gray or whitish columns. So with a 4-month treatment of penicillamine, we can lower toxic levels of copper in the liver back to normal levels. And also the lesions in the liver also disappear, so they were obviously reversible. I forgot to include how they treated these animals. Basically, they gave 10 milligrams per kilogram of penicillamine twice a day orally for those 4 months. So we can say that this is definitely a long-term therapy for a familiar accumulation of copper, but it's pretty effective. So this is my final slide, guys. We will continue talking about toxicants that affect the liver on the next one. So until then, take care and bye-bye for now.